Okay, we are setting up chapter 38. So give me a second to pull up the PowerPoint. Share my screen. Share. Stop share a minute. Just double checking really quick. Okay. You want to do this once.
Yeah, unlike the 3 or 4 times we had to do it for the last check.
I'm doing the best I can. I'm a boomer.
Okay, dude.
One more second. Okay. I'm going to share the screen. From the beginning. All right, here we go. And you guys. Yes, and both our greyhounds are here listening to you. They wanted to learn about this.
I already know about this.
Yep.
Hi guys, it's me again. This will be the final one and that I'll be teaching today. This is chapter 38, part of the cardiac lecture series. Care of patients with acute coronary syndromes. Let's go over the definition of coronary artery disease. This includes stable angina, acute coronary syndromes, ischemia, and infarction. This is an ischemic episode would be considered insufficient oxygen supply to meet the requirements of the heart muscle. All right. In other words, that's due to some kind of a calcification, some kind of a blockage, some kind of a dissection. This can also happen. Some young people will get what they call spontaneous intercoronary dissections that can cause a infarction. Infarction is necrosis or cell death that occurs with severe ischemia. In other words, it's so blocked off that there's absolutely no way you can get blood supply to that part of the heart that needs it. You'll see this is due to plaque buildup and plaque rupture inside the intima of the blood vessel that leads down the heart. Now, just a quick review real quick. Understand that there's a left main coronary artery. These all come off at the cusp of the aortic valve. Right above the aortic valve, there's little openings called ostia. And on the left side, you will see the left main coronary artery, and that branches off to the left anterior descending, which is if you hear people saying the widowmaker, left anterior descending covers over the left ventricle, and then the I just blanked. Oh, I wish I could pause on this sometimes. OM, not the OM, pause.
Zoom. Then we're going back to screen.
Okay, back again. Let's go back to where we were talking. Bring it to slideshow. There we go. Left anterior descending, circumflex, and over on the right cusp is the right coronary artery. Now, the right coronary artery kind of supplies to the back posterior. Circumflex kind of wraps around the anterior posterior section of the heart. Like I said, the LAD supplies blood to the anterior section of the heart. Now, necrosis or cell death that occurs at that, when you begin to do that, the heart gets really, really irritated. And what people end up dying from is actually an arrhythmia related to that actual ischemia and infarction process. The heart just starts to either fibrillate or go into what they call deadly arrhythmias. Now, and that's when you see people getting shocked out of those rhythms, either by an AED or by a defibrillator. Now, let's talk about chronic stable angina. There's people who complain about, I have chest pain all the time. Well, they may have heart disease to a point that can't be treated through cardiac catheterization. Now, if you look, you would want to look at, if you do a cardiac cath on a patient, and you happen to notice that they have like a 30% blockage or a 20% blockage. Now, granted, they have a certain amount of heart disease, but it's not as they consider at the point to be non-ischemic and be treated through medications such as nitrates, such as calcium channel blockers, and keeping the patient's blood pressure down where it's supposed to be, keeping them on aspirin so they don't form clot. And it says it's a temporary imbalance between coronary arteries' ability to supply oxygen and cardiac muscles' demand for oxygen. You'll see these people, and they can't walk far distance, but you can't really put a stent in it, or it's not worth doing a bypass because it's not bad enough. Now, they do get angina, and we have to treat that angina. There's various, you can give them nitrates to help with the chest pain. You give them some Ranexa to help with chest pain. Ischemia is limited in duration. It doesn't cause permanent damage to the myocardium. It just gives you a brief ischemic event. Now, there's ACS. This is unstable angina, where you'll have a patient that comes in, he's a diabetic, he's 52 years old, and he comes into the emergency room via ambulance, hopefully, saying that I feel like I have an elephant sitting on my chest. Now, you go ahead and you do an EKG, but there's also things you want accomplished before you do that. Now, you are assuming acute myocardial infarction. These people look bad. I mean, they are pale, they're sweaty, they're scared to death. Their heart rate is high with EKG changes, and they have an assumption of doom. In other words, I feel like I'm dying. And when you hear people say that, listen, really listen, because they're probably getting right. All right. This is what this is believed. So the belief is that an atherosclerotic plaque, which is inside the wall of a coronary artery, and it builds up. And I've talked to you guys about this before. As it builds up, what it does, it creates a narrow space. And this is applied hydrodynamic physics. As you decrease that space in that artery, under pressure, the pressure gradient, it gets higher behind that blockage. And going through that little bitty hole, it's like I'm telling you, you take the garden hose, you put your finger over the hole, and it goes with a higher pressure over a farther distance. Well, what that does over a period of time, especially with increased blood pressure, is it starts to tear itself apart. And you actually get a rupture of the wall into the wall. And a plaque will actually start to flip down, and it'll be like a flap. And then if you do a angiogram, it actually looks like a flap. And it'll start to get turbulent there. Platelet aggregation happens, thrombin starts to collect, and you form a clot and block off that artery. That's bad, it's very bad. Now, they talk initially about unstable angina pectoris. This is a new set angina. Variants, nobody calls it Prinzmetal's anymore. It's coronary vasospasm. Just think of it that way. In other words, people have, if they get overexcited, if they get an adrenaline rush, if they get scared, they start to get chest pain. What that is, it's due to the epinephrine that's being shoved out into their system, and it's causing coronary vasospasm. Or if they go up to altitude where the partial pressure of oxygen is lower, they'll start to get chest pain. Treatment for that is medication with calcium channel blockers such as Rapamil works very well. Norvasc works very well. This is a lot of this can be, like I said, be treated and treated successfully. You usually don't see an ST change with it, but their pain is real, and they really do have a squashed down coronary artery. But if they just relax, get some oxygen on, usually that redilates, and they're able to feel much, much better and actually completely relieve symptoms. Now, there's pre-infarction angina, which people will get. Those are the ones that we were talking about with stable angina. All right. In other words, no ST changes, no 12-lead changes, not have any troponin changes or anything like that. But what this is it's heart disease is a progressive disease. We are not curing heart disease. What we're doing is we're putting patches on it. So if a person has heart disease, he will progressively have heart disease the rest of his life. Now we can go in and do PTCAs, we can do bypass surgery, we can put stents in, but it's got to be his modification to the best of his ability and change the things he can change, all right, that will help him out. So patient presents with, there's the one where patient presents with ST changes on a 12-lead, but won't have any troponin or any CK levels. That is like an ST, but pre-infarction angina. Now, this is the acute phase of where it's blocked up. I explained to you how you actually get plaque rupture, where the intimal wall is pulled away. This is the most serious of acute coronary syndrome. You'll also hear it used as ACS, all right? Myocardial tissue abruptly, severely is deprived of oxygen. Occlusion of the blood flow, necrosis, hypoxia, and it can happen subendocardial, in other words, deep into the wall, transmural, inferior wall in mine. I mentioned that with the right coronary artery, but then there's the anterior wall in mine, which would happen over like with the LAD over the left ventricle. And they talk about ventricular remodeling. That means after the heart attack happens, as they get death to that heart muscle, that the ventricle actually changes in size because it'll shrink in specific areas. Now, we show the divided out between a non-STMI and an STMI. Let me grab my notes here real quick. Non-STMI, you'll see positive CKs and positive troponins. Those are the enzymes that are released during a heart attack. And then you'll see, but you'll see ST depression. You won't see so much of what they call tombstoning between the ST segments. Now, do they have an idea, Laura? Do they have an idea what an EKG looks like?
They haven't started critical care yet.
I know, it's not critical care. I'm just wondering.
Your book would have an EKG picture, and
Yeah.
you've seen it on a monitor, probably at the hospital.
Yeah, you have PQRST. ST is after the depolarization of the ventricle and the repolarization of the atria, all right? And what happens is you get ischemic through that area. If you notice on the left of the screen, you'll see that where the EKG is, you'll see a rise in that segment. That shows that that wall is being injured. In other words, it's a prolonged time frame now because it can't get that, it's not getting that relay signal down through it like it should, so it's going to rise. And if it's a partial non-STMI, you'll see depression in the same leads. In other words, it's not going to be an acute STEMI, all right, but it'll be a non-acute STEMI. It still is a heart attack, just not as acute. Let's see. Non-modifiable risks. Age. The older you get, you can't change time. Gender. Males are still above females, but ladies are catching up due to their stress levels. Family history. If like my dad died at 50 from an acute MI, and so I was only 22 years old at the time, and he passed that down to me. So I have a background, family history of coronary artery disease and ethnic background. Modifiable risks. Elevated serum cholesterol. And we already talked about the meds that could be involved in handling that, such as statins and the problem is with statins, you've got to take them, all right? People don't like taking them because sometimes they cause the muscles to ache. You get some kind of myalgia associated, especially with high levels of statins such as Lipitor. Cigarette smoking. You got to tell the patient, you got to quit smoking. Simple as that. It's going to kill you because it's a vasoconstrictor. You want those vessels to be nice and wide open, not tight and closed. So if if you take a cigarette and all of a sudden you start getting chest pain, I just have it. I put the cigarette out. I said, no, that's not it. Hypertension, high blood pressure, impaired glucose tolerance, diabetics. Diabetics have a 4 times of a chance of getting, if straight up with the diagnosis, 4 times the chance of having acute coronary syndrome or coronary artery disease. Of course, obesity, excessive alcohol, limited physical activity, sedentary lifestyle, and stress. Now, some of the lab assessments that we go through and look through are troponin and troponin I. These are both enzymes that are specific, and they do what they call trending. In other words, you'll get them initially when they come in the door. We'll get a trend level, and it can be, if you're looking at the troponin level for the first draw, and it's, let's say, at 6, 7, and then you notice the next draw, it's gone down to 2, 3. That means this all started 12 hours ago, 10 to 12 hours, because you have a certain rise, and then it'll dip down, all right, once you mitigate the problem, mitigate the chest pain. But if you take that initially and you still see it rising on the second draw, then you get an idea that this just started and we have to get going. CKMB, the only problem with the CK and the CKMB is if a person is exercising or is involved in some kind of trauma, your muscles alone will release CK. Your chest muscle, your heart muscle also elicit the MB fraction for that. Myoglobin, you don't see that drawn very much anymore, but the primary indicators are troponins. Imaging assessments, we can actually go in and do an echo to see how our wall motion is, see how our ejection fraction is, and see the actual pumping capability of the heart. Like, is the anterior wall moving worse, or is the inferior wall moving worse? 12-lead EKG, initially when the patient comes into the room, it's one of the first things we get because we want to see what the electrical activity is so we can determine if it's an ischemic or non-ischemic event. And then eventually we're going to take them to the cath lab. If they're having chest pain, if the 12-lead looks a little suspicious, if you've got a troponin rise, you're going into the cath lab. We're going to find out where your blockage is and then we got to make a determination how we're going to fix it. Pain management. Well, this isn't just pain management. This is like everyday management of any kind of patient coming in with chest pain. It's not just pain, but you want to take care of and alleviate their stress, and you want to help dilate their coronary arteries. We use a acronym called MONA, M-O-N-A. It's kind of in here and it's kind of not. But the primary is morphine sulfate. Morphine's a beautiful drug. Does a couple things that are really nice. One thing, it's a vasodilator. 2, it's a pain reliever. 3, it helps take their stress level down. and it helps them oxygenate better. So Mona, oxygen. Get them on O2 right away. Their body's craving oxygen. Put them on as high as an amount that's appropriate, because you want them saturated as heavy as you possibly can, because their heart is starving for oxygen. Nitroglycerin, beautiful drug, easy to titrate. What it does, it causes vasodilatation. These people usually come in with extremely high blood pressure because they're so anxious, and their cardiac demand says that they need the blood to get around where it is. So you give them that nitroglycerin. It dilates the vascular bed, helps with preload and afterload. And then the last one, and it's not mentioned in here, which is kind of surprising, and it is aspirin. You load them with, as nowadays, two regular aspirin, you have them chew it up. I know it sounds awful, and it kind of tastes awful. You can give them a little sip of water to help it get it down. But they find that it starts to buccally get going inside the mouth. And what that does, it helps stop platelet aggregation. It is a blood thinner. Giving aspirin initially in light of a STEMI or STMI stops and curtails mortality by 50%. It is the most potent medication you can give somebody. All right, ineffective tissue perfusion, cardiopulmonary interventions such as drug therapy. We just talked about this. Aspirin, number one. Thrombolytic agents. Now, there's various thrombolytic agents that are out there, and usually they're not given because we prefer you go directly to the cath lab now and get what they call door to balloon time, which is 1 hour. By the time that patient hits the emergency room, they want them on that table and the balloon in the heart opening up. Time is muscle. All right. Thrombolytic agents include such stuff as tenecteplase, TPA, retaplase. These can be given if you have the inability to get a patient to a cath lab. In other words, if you're out in the middle of the sticks in the high Sierras and you don't have a helicopter coming in here, but you're at an urgent care and you got to get this started and the guy's having an MI, then go ahead, give the TPA, get that open. And what it does, it's a clot lysing agent. However, the problems with that is bleeding. You'll see people actually, I've seen actually some horrible bleeding problems associated with that, because you have to go through a whole checklist asking the patient, you ever had this kind of bleeding problem or any kind of, no. And then you find out after you've given it, well, there was that one time I threw up blood, and you kind of go, but complete, and you want to make sure they get sustained reperfusion of the coronaries or coronary arteries in the first hour after an MI has decreased mortality. We just talked about that. TPA, retaplase, and tenecteplase. Glycoprotein 2B3A inhibitors. Now, during PTCA, there's different inhibitors that you can give, such as Aggrastat, Riapro. What these do is they thin the blood out. They really bring it down, given along with heparin. All right. You also want to look at Plavix, which is think of it as a super aspirin. And what it does, it makes the platelets extremely slippery. So after you do put a stent in, you don't want to have platelet aggregation in that area. You want everything to go through there nice and smooth and nothing to grab onto it. There's also Effient, but everybody gets an aspirin. That's for darn sure. Let's see. Cardiogenic shock. Now you've gotten to the point, if you actually had a patient that's had a full-blown MI, you get them in there and they have up to 40% of their left ventricle, not necessarily necrotic, but it can be stunned. And if it's left untreated, patient goes into shock. In other words, the heart muscle is pumping like this because it's hurt. Same thing if I took a baseball bat and smacked the back of your leg with it, you're not going to want to move it. You're not going to want to use it. The muscle's screaming in pain because lactic acid is now building up in it, and it's not getting the blood flow that it wants. 40% is the magic number. That's all you get. It goes to 50%, you're going to die. The patient will be tachycardic, hypotensive. In other words, patients with blood pressure will be very low. Cardiac output will be very low. Ejection fraction, very low. All their baselines, very low. Urine output's going to drop because the kidneys are saying, I got to shunt this blood somewhere else. I got to shunt it up to the heart so they can get some oxygen to it. You're going to see the urine output drop off. Now, they'll come in cold, clammy, looking like they're dying. Poor peripheral pulses because everything's shut down peripherally. They'll be agitated, restless, actual confusion because the brain's getting stolen too from some blood, and they're not making rational decisions. Pulmonary congestion, they'll start to go into a bit of heart failure because the heart's shunting. It's shunting blood away from the lungs even. They're going to be breathing real fast because they're oxygen hungry, and they're going to have crushing chest pain. Medical management, pain relief, morphine, wonderful, wonderful drug. For blood pressure, dopamine, dobutamine, increase your cardiac output. You may have to put multiple therapies on this patient. Intra-aortic balloon pump, and you want to get this patient to the cath lab to get immediate perfusion. But patients that are in cardiogenic shock, just putting them on the table, since they're already that risky, now you're going to be sticking wires and stuff up into their heart. You're making it a very high risk patient. One modality that we're using now is called Impella. You may have seen actually commercials on TV for this. This is an Impella. It's a catheter that we insert down into the left ventricle through the aortic valve. And if you'll notice, on the very end of it, you'll see a long tubular wire and then a little hook on the end. Well, right at that little hook on the end is an opening. And on the other end of it, if you look on the other side of the aortic valve, there's another opening. Inside that tube is a motor, micromotor, that spins. And what it does, this pulls blood out of the heart because the left ventricle can't pump like it could, up to 5 liters cardiac output flow a minute. There's a smaller device called the Impella 2.5. There's the Impella 5. All right, I've used both of them. And for patients that are in cardiogenic shock, it's almost like putting a left ventricular assist device in the patient. And I've seen it save lives, especially during coronary artery disease and horrible MIs. So PTCA, give Plavix before the procedure. Clopidogrel is the other name of it, or it can be Effient. Either one is fine, or Prasugrel. They're all super aspirins. All right. IV heparin during the procedure. I'm surprised they put after the procedure, but you got to give it during the procedure because you got to thin the blood out. So I'm putting wires. I don't want clots. Clots are bad for me. So is air injected into the artery. You don't want either one. Bad air, bad clots. So you want to get their activated clotting time. It's over 250, over 250 seconds. IV or intracoronary nitroglycerin or diltiazem. Diltiazem, of course, is a calcium channel blocker. Nitroglycerin is a dilator. 2B3A inhibitors, not used that much anymore. ReoPro, Aggrastat. Long tube therapy, antiplatelet therapy. We talk about what they call now dual antiplatelet therapy. Everybody that gets a stent after procedure gets dual antiplatelet. That would be with Plavix, Effient, and an aspirin. It's either Plavix or Effient, either one. And you give them a loading dose. So normal dose for Plavix is 150. You're going to give these people 600 before they go in. And then you could have long-term antiplatelet therapy. Beta blockers such as carvedilol, ACE inhibitors, or ARBs. And this is a brief explanation, kind of shows you quickly of what it looks like. Before they put that inflated balloon in, is like was shown in number 2 there. And they are working on, as I mentioned before, the artery that comes off the left cusp of the aorta. It would be the right coronary artery. They put a wire down through it. And like I mentioned before, when we talked about PTA, not PTCA, they have to put a wire past that blockage so that they have some kind of a guide that they can put through that. This is an old picture. We put the wire on, then you can put the balloon over the wire, then you inflate it, and it smashes all that plaque up against the arterial wall. Then they can put a stent in. We'll talk about stents here real quick. You can also do what they call an arthrectomy, and that can be done with a rotablator, which is basically a type of drill with a diamond tip on the end of it, and you'll actually go in there and buzz out that calcification. Or you can use laser beam therapy. You can actually put a small ruby laser down there, puff, 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 and what it dissolves the actual calcification. We can put stents in, and that would be after the arthrectomy. We want to keep that vessel wall open. And then you can go to rheolytic thrombectomy. I haven't used that in probably 15, 20 years. That's where you actually put this. It's a machine where you put a tube down, you inject fluid down into it, and then you suck it back out. They find that it has too much of a showering effect. But yeah, we just don't use it. This is a stent. A coronary stent is, by its own definition, a metal tube. And think of it as a chain link fence that is rolled up. And what it does is you put the balloon inside the chain link fence, squish it on the balloon so that you're able to put that inside the artery, inflate the balloon, stent locks itself open, and you're able to pull that balloon out. One of the problems that we had with stents was they would restenose. In other words, they would close themselves back down. What we found out is that if we put certain kinds of chemicals and drugs on the ends of these, such as sirolimus or Taxus, these are both types of chemotherapeutic drugs, we were able to stop that restenosis of that and cut it way back. What it does is it stops the cellular growth. We don't want to kill the cell that on the intimal wall of that artery, but we want to attenuate or slow down the wall growth. So what this does, it stops it. If you remember your microbiology, that there's 4 phases of cellular growth. This attenuates the growth of those cells at the second part of that phase. So what you're doing is you're stopping that tissue aggregation in that area. Now we can talk a little bit about bypass. Bypass is we're taking vessels from the leg, attaching them to the aorta, and putting jumper grafts down ahead of the blockages on the coronary arteries. In light of how good, excuse me, I gotta get just a little drink here. In light of how well we've been using, interventional cardiology has been using and taking care of blockages, there are still rarities that we do see bypass grafting. A lot of times in certain adults, especially younger ones, have a better outcome, especially diabetics. They're finding there's different arms that we can look at, have a good outcome if they get bypass grafting at an early age, early time, over a longer period of time. They do better, right? So what they're putting it through is, this is where they show you where they attach the pump, goes into the inferior vena cava, out the vena cava, in through the oxygenator, into the filter bubble trap, and then drops it back down into the aorta. And this is, the patient doesn't even have, the heart can be stopped because the blood is being oxygenated and routed through a machine. And then they can actually do the bypass grafting. Here's a depiction of some saphenous vein grafts coming off the aorta. You got one going to the right coronary, one to the circumflex, another one down to the LAD. And over on the left side, you're seeing directly from internal mammary graft artery that comes off the left subclavian. And what they do is they actually jumper that off and put it straight down. They find that internal mammary graft arteries last way longer because it's an artery. It's way thicker than the saphenous vein grafts or the vein grafts. Now, they can also do a radial artery graft where they take the radial artery out of the hand. And if you know, we've got two arteries we got the radial artery and you have the ulnar artery. Thank you. And surgical management, minimal invasive direct coronary artery bypass. In other words, they all do this endoscopically and they do it through little scopes. Endoscopic vessel harvesting actually assisted in this, where they go through the legs with the scope and they're able to take down and pull out the saphenous vein. Transmyocardial laser revascularization, but we've already mentioned that, where we can actually take a laser in there and revascularize that area that's been blocked off. We can do off-pump coronary artery bypass. That's only usually for a single graft. You don't want to do a multi-graft on that because the heart is still pumping and still working. And now you're trying to get that attached to a specific area and everything's moving in front of you. It's like, okay, I want you to change the carburetor on this truck while it's going 40 miles an hour. And you can also do robotic heart surgery through a very small invasive graft, non-invasive grafting, and actually work on it through a robotic hand-driven device. And I only know of one surgeon here in San Diego that does that. Community-based care. This is after you're getting things done and you've actually taken care of the patient, and now you got to send them home. One of the big things that I always talk about and always try to drive home is compliance. They have to take their medications. If they stop taking their Plavix, especially within 3 months of getting that done, that vessel will close back down. They will have another heart attack. And since they just had one less than 90 days ago, chances are it's going to kill them. And you have to teach self-management and how to take care of yourself, how to lose that weight, how to modify what you can modify. And there's various healthcare resources out there, American Heart Association, American Diabetic Association, that can also help you with care resources out in the field. Public health can also come out, and public health nurse can also come out and see these patients. And they also have to follow up with the cardiac care unit afterwards, along with the cardiologist.
Okay.
Not that good one.
All right.